Good afternoon, everyone. My name is Steve Abbott, and I'm the Executive Director of Cincinnati Cancer Advisors. Welcome to our first ever, but second actual Cincinnati Cancer Advisors Medical Minute podcast, where we'll attempt to explain complicated cancer topics in a way that makes cancer easier to understand for patients. At CCA, our motto is great care begins with a great plan, and our goal with this series is to provide vital information that will help patients formulate a better plan of care along with their treating physician. And now, without further ado, I'd like to introduce my co-host, Jill Hunt. Jill is not only my colleague, but she's an oncology nurse practitioner with more than 20 years experience, the last 17 years of which has been in combination with Dr. Phil Lemming, our medical director. Jill and Dr. Lemming saw more than 200 patients last year, even during COVID, and their consultations spanned almost 40 cancer types. So they see pretty much everything. Our first series of topics today will cover prostate cancer in honor of Movember, which promotes awareness of men's health issues such as prostate cancer, testicular cancer, mental health, and suicide prevention. Welcome, Jill.
Thanks, Steve.
So, as I mentioned, what we're going to try to do is make things a little simpler for people to understand. And one of the things I talked to Jill about this morning is that I think something even as simple as I don't even know that cancer patients necessarily even understand what cancer is. I mean, like they know it's bad. They know that it could potentially be fatal, but do they really understand, like at a cellular level, what's happening, what's going on in their body? So let's just start real basic. What is cancer? What's going on? What's going wrong?
Okay. So if we went down to the basic definition of what cancer is, and easy place to start, and where I like to refer a lot of my patients for credible information, would be the National Cancer Institute. How they define cancer is a disease in which some of the body's cells grow uncontrollably and it spreads to other parts of the body. So cancer can start almost anywhere in the human body. And taking into consideration that the human body is made of trillions of cells. And normally these human cells grow and they multiply through a process that's called cell division, okay? And what that does is it forms new cells as the body needs them. So when these cells grow old or become damaged, they die and then new cells take their place. So the problem is sometimes that process goes a little wonky.
Okay.
And those abnormal and damaged cells grow and multiply when they shouldn't.
Got it.
So these cells can form tumors, which are lumps or clumps of tissue, and these tumors can be either cancerous or non-cancerous or benign. So the cancerous tumors, what makes them a little bit different is they can spread to different parts of the body. And that's where you get terms like metastatic from.
Yep.
Okay? And many cancers form solid tumors, but cancers that start in the blood, like leukemias or lymphoma, or well, not lymphomas, but leukemias or other types of blood malignancies, those typically do not form solid tumors.
Got it. No, it's a good answer. So let me ask you this. So particularly since we're here to talk about prostate cancer today. So prostate cancer has the reputation of being, well, I think some would say very curable. Now, as we know, that there's a spectrum and a continuum of what those results and outcomes can be. But why is it that prostate cancer is considered the good cancer? Why is that? Why is that when a little less likely to scare people half to death?
So traditionally, prostate cancer is pretty slow growing. And when you look at actual survival numbers at the time of diagnosis, and this is something that most clinicians are looking at, they're looking at what the survival numbers are at like the 5-year survival rate. When you're looking at early stage prostate cancer diagnosis, these patients have a 98% 5-year survival. Wow. And so what that means is at 5 years, 98% of patients that are diagnosed with early stage disease are still alive.
Okay.
The other piece to this is a lot of patients, especially when they're diagnosed early, they don't even need to actually start treatment immediately. They call it like active surveillance, where yes, they may have an active diagnosis, but they're in such a good spot that they can actually just sit back and monitor over time to see what their cancer is actually going to do.
Gotcha. So one of the things we always talk about is one of the things at least we hope for. We tend to see patients after they've been diagnosed, but clearly we have a great interest in early detection. So what are the kind of things that, given that prostate cancer is so curable if caught early, what are the kinds of things a man can do to try to catch it early?
So the number one most important thing is making sure that they are seeing their family doctor on a yearly basis. This isn't just for prostate cancer, but obviously can pick up other things. There's health screenings that are routinely done to watch for all different types of not only cancers, but other health conditions. But as our population ages, and especially once just general population men who don't have any other risk factors, once they hit 50, they should be having those yearly PSAs done along with their regular physical exam and other lab draws that are being done.
Yep, no, it's so true. There's confusion, and as you know, these guidelines tend to shift a little bit here and there depending on updated studies and things like that. The common denominator that I think drives everything is family history, particularly when it comes to prostate cancer.
Correct.
There probably aren't too many cancers that are so clearly defined by family history as prostate. But can you take people through kind of what are the current guidelines, just so if someone is watching this and kind of knows where they fall age-wise, what they should be doing?
Okay. So the current recommendations for PSAs, they should start at age 50 for men who are at average risk. And beyond that, when we start looking at people who are at higher risk, so someone that would be African American with a first degree relative, which would be a father or a brother, diagnosed with prostate cancer at an early age, these men actually need to be starting their PSAs at an earlier age, around 45. To notch it up another level, men who have more than one first-degree relative who have had a prostate cancer diagnosis at an early age, they actually should start their PSA at age 40.
Yeah. And I've read, and you can tell me if this is wrong, but I've read that even tends to be cumulative. As there's more and more family history, the risk gets even greater and greater. So it's even more important for those guys.
Correct.
So let me ask you this. So we're sitting here and it's like, okay, so if we stipulate and agree that getting a PSA itself is not difficult, it's a blood test. Mm-hmm. It's not expensive. It's not difficult. In order to properly diagnose, there's other procedures that are less fun than a blood test. But just to get a baseline, like on a PSA, why wouldn't a guy just go start getting them when he's 30 years old? But because you look at these guidelines and they're not encouraging anyone young to go. Why is that?
A lot of it, and they've actually looked into studies looking at checking PSAs earlier and seeing if that actually improves the overall survival and decreases the risk of people dying of prostate cancer later in life. And there's been a lot of conflicting data, and they haven't been able to truly prove that checking it earlier, like when men are in their 30s or potentially even younger, that actually has any benefit to the overall survival related to prostate cancer. The other thing that you have to take into consideration is that prostate cancer isn't the only thing that can elevate a PSA.
True.
And so sometimes you can get what they call a false negative or a false positive. So false positive would be that you had a positive PSA that was elevated and people assumed that it was related to prostate cancer. So then they move on to doing a prostate biopsy. And when you're dealing with anything in the medical community, you're always looking at risk and benefit. And so doing a prostate biopsy isn't without risk. And so if you have someone who has a false positive on their PSA for an elevation that was not prostate cancer related, and then that person goes through having a prostate biopsy that may not have actually been needed, you're exposing them to the risks of the anesthesia, the potential post-operative risks. And then if you do get an early diagnosis, sometimes there's a little bit of a knee-jerk reaction, and you can't always, with 100% accuracy, determine the aggressiveness of the cancer. And so sometimes that early detection, sometimes you can end up with over-treating in that scenario.
Yeah, no, it's a great point. And the interesting thing about that you mentioned other potential factors is, things like either recent sexual activity or some people even cite cycling, certain types of exercise. There are things that younger guys tend to do that maybe older guys aren't doing.
Correct.
And so that could even lead to a potential, false positive, as you said. So I think that's an important thing to point out. So anyway, episode 2, I think we'll continue to do this. Episode 3, we'll continue talking about prostate cancer with some more questions that we'll go through. The goal of these is to answer questions in approximately 1 minute each. I think we're close. And so anyway, thanks again, Jill, and we'll talk again here shortly.
Okay, sounds good. Thanks.